Dear ladies and gentlemen, greetings from the Malaysian Obstetric Medicine Society. And it is time to discuss a modern concept, which I'm going to call it the five trimesters. Now, ladies and gentlemen, I think we need to reflect on the rationale, on the logic, and on the evidence of having three trimesters. And this is what I believe modern obstetrics should be all about. It is no longer the three trimesters, but we need to divide pregnancy into five phases. And that is what I'm going to call the five trimesters, a novel concept in obstetrics. Now, ladies and gentlemen, disclaimer, this is purely based on my own perception and thoughts. Please do not quote this in exams, but I believe it is time that we relook obstetrics in a different perspective and divide it into five different phases, which I've called, for the sake of simplicity, the five trimesters. Now, the next 35 minutes, I'm going to talk about the rationale about dividing into three, the rationale about talking about five trimesters, and the way forward on what we need to do on each trimester. Ladies and gentlemen, let's go back in history. The term obstetrics comes from the Latin word obster, which means to stand before. But fast forward in modern obstetrics, ladies and gentlemen, to stand before a pregnant mother alone is not enough. Obstetrics has fast evolved, and I believe the modern obstetrician should not just stand before, should not stand behind, but should stand beside every single pregnant mother. It is no longer merely intrapartum care. It is not just antenatal care. It is not just postpartum care, but we need to be there in the entire spectrum of obstetrics, which is before pregnancy, early in the pregnancy, midway, the last stages, intrapartum and postpartum care. And I believe that is the concept of modern obstetrics. So, ladies and gentlemen, for the sake of logic, I believe in the past, we have divided pregnancy into three phases. The first trimester, known as the period of organogenesis, and this is divided as the first trimester. Then the honeymoon period, the second trimester. And finally, the last 14 weeks of pregnancy was called the third trimester. I've tried my level best to look for evidence, but what I could find was merely logic and rationale, not strong concrete evidence. And hence, ladies and gentlemen, the pregnancies were divided into three phases purely because of logic, simplicity, and rationale, not based on concrete science. Ladies and gentlemen, let me put forward one question. In the entire journey of a mother towards motherhood, which phase do you think is the highest risk of mortality for her? Is it very early on in the pregnancy? Is it midway through the pregnancy? Is it later in the pregnancy? Or is it after delivery? Ladies and gentlemen, which is the highest risk for a pregnant mother? It is actually postpartum. 45% of mothers in the US actually die within 42 days after delivery. And the postpartum period, which I'm going to call as the fifth trimester, seems to be the riskiest part. Now, we have got a systematic, standardized approach of antenatal care, where pregnant mother sees the health caregiver 10 times in the antenatal phase. No other time in her life will she come in contact with 10 healthcare professionals in 10 months. But the postnatal period, the most essential, the crucial, the most dangerous phase, she only comes in contact once on day 42. And this is one of the reasons on why we think mothers die. And this is one phase that we should really pay particular attention from here onwards. So ladies and gentlemen, I'm sure you have seen these slides many times. This is the MMR based on causes of death in Malaysia from 2000 to 2018. Medical diseases was the top leading cause of maternal deaths for many years, but now it is the second leading cause. The top leading cause in Malaysia is postpartum hemorrhage. So way back in the H1N1 pandemic between 2009 to 2011, significant amount of deaths from the H1N1 pandemic. Then the leading cause was cardiac diseases in pregnancy, then was pulmonary embolism, but now PPH. But ladies and gentlemen, the top 4 causes in Malaysia is PPH number 1, hypertensive disorders number 2, pulmonary embolism and amniotic fluid embolism, 3 out of 4 of which happens in the postnatal phase. Hence, significant amount of these mothers actually die in the postnatal period. So what are the 5 trimesters? So what are the 5 phases that I think we should now focus in modern obstetrics? The first phase, I'm going to call it the 0 trimester or the first trimester, is the first 12 weeks before pregnancy, and that is known as the pre-pregnancy care. The second trimester is the first 12 weeks during pregnancy. The third trimester is between 13 to 28 weeks. The fourth trimester is between 28 to 39 weeks, not 42 weeks. And finally, the most crucial phase after pre-pregnancy is post-delivery phase, which I'm going to call the 5th trimester, which is 12 weeks after delivery, where 1 in 2 pregnant mothers around the globe, be it US, UK, or Malaysia, actually die during pregnancy. And these are the 5 trimesters that I've called for the sake of simplicity. So let's first take a look at the first trimester. The first 12 weeks before pregnancy, also known as pre-pregnancy care. Now, ladies and gentlemen, if we as a nation are to make an impact with regards to medical diseases in pregnancy, if you're going to save mothers and reduce complications, pre-pregnancy care is the key. And it is what a pregnant mother does 12 weeks before embarking on the pregnancy. Some people need longer than 12 weeks, but the first 12 weeks just before pregnancy, I think, is extremely vital. So pre-pregnancy care is not something new. There are actually 13 domains in the pre-pregnancy care, and it is the holistic care of emotional, physical, and psychological care. But for the sake of simplicity, I've divided it into 10 steps. Although 1 in 2 pregnancies throughout the world are unplanned, it is extremely important to plan a pregnancy just as intensive as how someone plans a marriage. It is good to plan ahead. It is good to take supplements, especially folic acid, especially 4 weeks before pregnancy for low-risk pregnant mothers, or 3 months high doses for high-risk pregnant mothers. It's important to ensure that mothers actually lead a healthy lifestyle, and nutrition is important. Achieving normal BMI of 28.5, exercising, quit smoking, passive smoking. What the partner does also affects the mother. So quit smoking is extremely important. Screening for non-communicable diseases, especially diabetes, thyroid, which is highly prevalent in Malaysia. Ensuring pregnant mothers are optimal at health, vaccinating, especially COVID and boosters. Reviewing the medications and talking to the doctor on pre-pregnancy care and how they can improve their care during pregnancy are the 10 steps. If the mother's high risk, then you need to do an additional few steps. For hypertensive mothers, you need to talk about aspirin. For diabetic mothers, they should embark on a pregnancy once their HbA1c is below 48 millimoles. For those with cardiac diseases, you improve their care before getting pregnant. For those with SLE, you treat them so that they're stable at least 6 months before. For epileptic mothers, no mothers in the reproductive age group should be on sodium valproate. We should aim towards zero sodium valproate in the woman in the reproductive age group. Or if they're on sodium valproate, they should be on contraception. For mothers with previous preterm deliveries, you should talk about how to reduce the risk, especially infections, optimizing treating cancers to improve care, including mental health as part of our care towards pregnant mothers. And these are certain steps that you can do in the pre-pregnancy phase for high-risk pregnant mothers. So, ladies and gentlemen, if I was to summarize the steps in the first trimester, or also known as the first 12 weeks before pregnancy, ensure that a mother achieves a near normal BMI, a target of 28.5, which is the Asian BMI classification. Ensure she is healthy, she exercises, she is of optimal health. Ensure there's no active or passive smoking, there's no exposure to alcohol or substance misuse, both the mother and her partner. It's an important time to screen for non-communicable diseases, diabetes, hypertension, thyroid diseases, anemia, thalassemia, which are highly prevalent in these parts of the world. Vaccination, the flu vaccine, the rubella vaccine, the COVID vaccine, the COVID booster, the hepatitis B vaccines are some of the vaccines that you should be advocating and talking to women in the pre-pregnancy state. It takes two to tango. It is not just the mother's health, but the father's, the partner's BMI, the partner's lifestyle, the partner's incidence of infections also can affect the fetus and manifest as preeclampsia. So it's important to include the partner's health in pre-pregnancy care. Mothers should be supplemented with folic acid routinely 4 weeks before pregnancy, or if they are at higher risk, 3 months before. And vitamin D is one vitamin which is slowly showing its significance, especially in those who are deficient for vitamin D, especially those who are obese, those who are tanned, and those who are covered. For mothers who have got underlying medical diseases, it's important to ensure that the underlying medical diseases are controlled, are optimized, not to diagnose them during pregnancy, but to diagnose them before pregnancy, control, and then embark on a pregnancy. It's important to plan every single pregnancy and to empower every single mother and partner about the importance of planning every pregnancy. And for those with subfertility issues, we should address these issues, talk about lifestyle interventions and how we can improve outcomes. And these are the 8 steps in the first trimester. Let's move on to the second trimester, the first 12 weeks of pregnancy, which is a period of organogenesis. Now, what is important in the first 12 weeks of pregnancy? 1 in 6 pregnancies will fail in the name of a miscarriage. The incidence of ectopic pregnancies, especially non-tubal ectopic pregnancies, are on the rise. It's important to ensure, to diagnose, to support these mothers who have got a 15% chance of pregnancy loss in the first 12 weeks. Mental health is extremely important. Ladies and gentlemen, many couples suffer in silence. It's not just a miscarriage. It is a fetal, a pregnancy loss. So it's important we support these mothers. It's also important to date to confirm viability in the first trimester. Ladies and gentlemen, nausea and vomiting is not just normal in pregnancy. It is not psychological, but nausea and vomiting has to be addressed. If a mother is deficient in terms of nutrition in the first trimester, that is going to affect her and her pregnancy. So it's important to ensure, to address, to empower, to educate, and to intervene nausea and vomiting in pregnancy. Now, why do pregnant mothers vomit in the first 12 weeks? My evolution theory is to prevent them from congesting potential toxins because this is the period of organogenesis. So it is nature's way of preventing mothers to overeat or even to eat. And that, I believe, is one of the ways to protect the fetus. So talk about lifestyle, about nutrition in the first 12 weeks, not what you eat in the second or the third trimester, but what you eat in the first trimester and 12 weeks before. Now, the incidence of VTE is high in the first trimester. This is contributed by nausea and vomiting. It is important to ensure that the mother is well hydrated. Think of VTE. The mother has got assisted reproductive techniques. Think about OHSS, which is also prevalent in the first trimester. It's also a time to screen for fetal well-being. It's a time to screen for fetal structural and genetic causes. Ladies and gentlemen, the first trimester screening is no longer about Down syndrome. We have evolved from a single disease to many other genetic conditions that can now be screened. Apart from trisomy, we can also screen for monosomy. We can also screen for zygosity for twins. We can also screen for Digeorge syndrome. So the first trimester non-invasive screening has evolved in a big way. It is not just Down syndrome in modern obstetrics. It is also important to screen for preeclampsia, because if you screen just based on risk, you're going to lose 1 in 2 mothers from preeclampsia. So it's important to add a uterine artery Doppler or a biomarker, and it'll increase the sensitivity from 45% to 75%. And the first trimester is also an essential time to screen for mental health, because please remember, 1 in 6 pregnancies will end up with a miscarriage that may have significant implications and consequences to the mother. And that forms the gist of my second trimester. Let's move on to the third trimester, the honeymoon phase in pregnancy, which I call between 13 to 28 weeks. And what are the principles of the third trimester? Nutrition is important. Do not deny a pregnant mother the importance and the essence of exercising. Non-weight-bearing, mild to moderate exercises are safe. It's important that a pregnant mother maintains a healthy lifestyle so that increases the chances of having a successful pregnancy, shorter, quicker labor, more natural, and a higher chance of a child. Talk to her about exercise and lifestyle. The second trimester, it's also an important time to take a look at fetal anomaly, which is already perhaps done and should be done in the first trimester. The second trimester anomaly is to reinforce the first trimester screening. The third trimester is also an important time to prevent preterm, because this is a period of gray area which defines viability and non-viability. So preterm prevention, especially in the name of preventing an infection, is extremely important. This is a period where you should screen for GDM, ideally at 24 to 28 weeks. And the second trimester, ladies and gentlemen, is also a time of significant stress on the mother. Pay particular attention between 22, 24 to 28 weeks. And this is what I call as the cardiac stress. The mother develops tachycardia. The mother develops breathlessness if she's unable to lie flat. This is where many other diseases may manifest. If the mother sails through this period smoothly, she will highly likely have an uncomplicated pregnancy. But the stress of the second trimester, the time where the cardiac output maximizes, is not a honeymoon period. It's an important time to assess, to address, and to ensure that nothing has been missed and no underlying diseases have been missed. It's also important to assess fetal growth. Apart from the first trimester scan, apart from an anomaly scan, it's perhaps worthwhile to do a 28-week scan to detect early fetal growth restriction. Next, the fourth trimester. And this is what I call the phase between 29 to 39 weeks. Ladies and gentlemen, we have moved away from the upper gestation of 42, or 41, or of 40 weeks, because now 39 weeks seems to be the safest upper gestation. If you have a protocol to deliver mothers at 39 weeks, there's a lower incidence of meconium, lower incidence of stillbirths, lower incidence of cesarean section, and in fact, even IQs of these babies tend to fare better. And I, for one, believe that we should move away from 42, but we should have and offer all pregnant mothers the benefits of an induction at 39 weeks for all uncomplicated singleton pregnancies. So what are the gists of the fourth trimester? This is the time where the pregnant mother complains and has got numerous symptoms: lack of sleep, constipation, GERD, reduce in appetite, back pain. All of these are not normal, and all of this should be addressed. It's important to ensure that a pregnant mother remains well and copes well throughout pregnancy. Apart from the 28-week scan, perhaps you should also have another scan between 32 to 34 weeks. Take a look at the fetal growth. And although some people believe in the inverted pyramid of the antenatal care, ladies and gentlemen, please do not forget preeclampsia, which commonly happens near towards labor. Do not forget the importance of checking blood pressure, because preeclampsia may develop the later stages of pregnancy. This is a time where you can have stillbirths, because we have not mastered the art of preventing term stillbirths. Although some people postulate that middle cerebral artery Dopplers are valuable after 34 weeks in preventing term stillbirths. And I, for one, ladies and gentlemen, believe in this concept of pre-delivery screening in ensuring maternal and fetal well-being before a mother goes through labor, which is equivalent to a marathon. So what is pre-delivery screening? Screen for GBS, ensure she does not have an infection. Perform a hemoglobin count, ensure she's not anemic. Perform a fetal ultrasound scan, ensure that the fetal is optimally grown. And I believe this pre-delivery screening, a scan just before delivery, is extremely vital to ensure that the mother and fetus is at optimal health before going through labor. And I believe this is equally important and a concept that we should perhaps reflect and take forward on. And finally, talk about when to deliver, where to deliver, how to deliver, and document her intrapartum care, which should be individualized. And these are all the essence of the fourth trimester. And finally, ladies and gentlemen, the fifth trimester, the period after delivery to 42 days, the most crucial period in a woman's pregnancy journey. And here are the reasons why. Ladies and gentlemen, let's take a look at the Malaysian data and the timing of maternal death from 1991 to 2018. Over this period, ladies and gentlemen, 55.9 mothers who died in the postpartum period. 30% died in the antenatal period, only 6.8% intrapartum, and 6.8% early in the pregnancy. So ladies and gentlemen, just like the US data, 1 in 2 mothers die in the postnatal period, in the 5th trimester, a time where the care is fragmented, a time where women are not reviewed timely, a time where women do not have access to specialist care. And it is the 5th trimester, which is the most crucial part in a woman's life. If you go back into the causes of maternal deaths, PPH happens postpartum. Hypertensive disorders in pregnancy can manifest postpartum. In fact, 44% of them happens postpartum. Pulmonary embolism is more prevalent postpartum. Antenatal thrombosis are DVTs, but postnatal thrombosis are pulmonary embolism. And of course, medical diseases, especially eclampsia, especially cardiomyopathies, especially epilepsies, can occur in the postnatal period. And that is why, ladies and gentlemen, it's important that we shift our focus and we strengthen our 5th trimester, our postnatal care, if we are serious about reducing maternal deaths in Malaysia. Let's take a look at some common causes. And as mentioned earlier, the leading cause is PPH, which happens postpartum, hypertensive diseases, which happens postpartum, amniotic fluid embolism is intrapartum, but pulmonary embolism and medical conditions, the top 5 causes of maternal deaths in Malaysia, are all more common in the 5th trimester, the postpartum state. Ladies and gentlemen, why is this important? Let's take a look at the trends of maternal mortality rates. From 1963 to 2018, we have done tremendously well. From 210 mmR, we now hover around 23.5. But ladies and gentlemen, let's take a closer look. For the last 22 years, we have been static, and our MMR has been hovering between 24 to 23.5. 1 in 2 mothers die in the postnatal period. And I, for one, believe if we shift our focus to the 5th trimester, if we can strengthen the postpartum care, we will be able to 50% reduce the incidence of maternal mortality rate in Malaysia and drive this down further. I believe the clue lies in the postnatal care. Why is that so? Because despite having an MMR of 24, we have realized for a long time that almost 70% of these deaths are preventable, especially in the postnatal period. So ladies and gentlemen, when in the postnatal period is most crucial, for all the disbelievers in the audience, you may say it is actually soon after intrapartum. And it's an intrapartum event and not a postpartum event. And this slide is to prove you're wrong. Now, mothers do not die in the first 24 hours after that. It is only 30%. But the highest risk seems to be 10 days after delivery. That was in 2016. If you take a look at 2017, it is also not within the first 24 hours, but it is 10 days after delivery. And similarly, in 2018, 40% of mothers died in the postnatal period 10 days after delivery. So the crucial period, lesson number 1, is postpartum. The crucial period is 10 days after delivery, a period of time that most of these mothers would have been discharged. Let's take a look at US, ladies and gentlemen. As mentioned earlier, based on the report from 9 maternal mortality review committees, 45% of deaths in the US happens within 42 days, which is equivalent to 1 in 2 maternal deaths, and only 38% happens while pregnancy. If you take a look at the causes, hemorrhage is the leading cause, cardiovascular diseases is the second cause, infection, cardiomyopathy, and embolism, all of which are same like in Malaysia, all of which are more prevalent in the 5th trimester. Let's move on to UK. If you take a look at timing of maternal deaths in the UK, once again, it is the postnatal period which has got the highest risk of maternal deaths. It is between day 1 to day 41 that 48% of mothers die in the UK as compared to 45% in the US and 55% in Malaysia. So ladies and gentlemen, in US, in UK, in Malaysia, it is the postnatal period which seems to be the highest risk. And this is the period which I believe we should now shift our focus to. Let's take a look at the maternal mortality rates in UK. Cardiac diseases, postpartum. Thromboembolism is the second cause, postpartum. Neurological emergencies, seizures, epilepsies, eclampsias, postpartum. Suicide and mental health also happens postpartum. Sepsis also happens postpartum, and hemorrhage. So ladies and gentlemen, the top 6 causes of US all happens postpartum, a similar trend in Malaysia and in the US. Coming back to Malaysia, The slide I highlighted earlier showed that 55% of mothers from 1991 to 2018 died in the postnatal period. And if you quote the most recent confidential inquiry report from 2009 to 2011, 59% to 56% to 64% of mothers died in the postpartum period. So, ladies and gentlemen, that brings to the concept that I would like to highlight that a postnatal period seems to be the period of highest risk. And this is the period which I believe we need to strengthen. And do not see the pregnant mother on day 42. Do not confine the pregnant mother. In fact, no mother should be confined. And do not do anything on TCA 6 weeks. This is the time where we need to review them soon. This is the time where we need to include a specialist. This is the time where care has to be holistic, as integrated as the antenatal period, because this is the time where 1 in 2 mothers in Malaysia actually have a mortality. How to reduce mortality in the 5 trimesters? I suggest we focus on 4 key elements: obstetric medicine, especially cardiac diseases and cardiomyopathy, which is the leading cause of cardiac-associated medical deaths in Malaysia, because this can manifest up to 5 months. Focus number 2 is thromboembolism, which is highly prevalent in the first 3 weeks. Focus number 4, we need to talk about mental health, which is also prevalent, where 1 in 2 mothers suffer in silence. And finally, we should strengthen the plan, the management in the postnatal period, also known as the 5th trimester. So, ladies and gentlemen, these are 5 medical conditions which are highly prevalent: eclampsia, VTE, sepsis or infections, cardiomyopathies, epilepsies, and mental health. And I'm going to spend the next few minutes to dissect each of these causes to strengthen my case. Ladies and gentlemen, 44% of eclampsia happens in the postnatal period. If you take a look at the confidential inquiry report, 67% of mothers died in the postnatal period from hypertensive diseases in pregnancy. So that is fact number 1. Hypertensive diseases are more prevalent in the postnatal period, where they present with intracranial hemorrhage or they present with an eclampsia. If we take a look at VTE, now this is an important chart which takes a look at the risk of VTE after delivery. VTE has got 2 peaks, ladies and gentlemen. Peak number 1 in the first 12 weeks of pregnancy. The second peak is the first 3 weeks after delivery. And so the risk is highest up to day 42, but it is the first 3 weeks which has got the highest risk. And this is one of the leading causes of deaths of mother, especially in the postnatal period. And this wonderful paper by the New England Journal of Medicine takes a look between the risk in the first 3 weeks as compared to subsequent 3 weeks. And it is what has been proven in other papers. The VTE risk is highest in the first 3 weeks after labor and delivery. Let's move on to cardiac diseases in pregnancy. So, ladies and gentlemen, for many years in Malaysia, in the early 80s and 90s, it was rheumatic heart disease which was the leading cause. But now, if you take a look at the incidence, it is a combination. It is equally divided between rheumatic and congenital heart disease. In the developed countries, in US and UK, it is ischemic heart disease. But one leading cause in the UK, in the US, in Malaysia, is cardiomyopathy. And cardiomyopathy may present in the last month of pregnancy or up to 5 months after delivery. It is a postnatal disease, and cardiomyopathy is associated with a significant increase in mortality. It is not treated, diagnosed, and managed by an expert. So cardiomyopathy also happens in the postnatal period, the incidence where it is most common. Suicide, ladies and gentlemen, the incidence of postpartum blues is 40%. 1 in 2 mothers will suffer from postpartum blues, or the incidence of depression. The incidence of mental health is far more prevalent than what we perceive. If you take a look at the incidence of suicide, when in the postnatal period is the mother at the highest risk? Now, based on the Embrace report, it is days between 183 to 273. So, ladies and gentlemen, some magic numbers in the postnatal period. The first 10 days is got the highest risk of death. After 10 days, the first 3 weeks, highest risk of VTE. That's the first 183 to 270 days, the highest risk of mental health. Because these women suffer in silence for a prolonged time before they realize they cannot cope, and the incidence of suicide hence manifests. Now, sadly, ladies and gentlemen, if you take a look at the type of deaths, the deaths among women tend to be more violent. The death among women in the postnatal period tend to be more violent. And these violent deaths are highly prevalent between 43 to 90 days. So, ladies and gentlemen, we should actively seek, we should actively look, screen, detect mental health. Women suffer in silence. It should be one important component of postnatal care, a component of a fifth trimester. Another important medical condition, epilepsy. And the magic word is SUDEP, sudden unexplained death in pregnancy. And although epilepsy can manifest in the antenatal period, the risk is highest post-delivery, the time of where a mother lacks sleep, the time of where a mother breastfeeds, the time of where a mother is lethargic. And this is a time where the risk of SUDEP is highest. And so epilepsy also manifests in the fifth trimester. Sepsis, ladies and gentlemen, is highly prevalent in these parts of the world. It is not COVID, of course. We are COVID now since 2021 and 2022, but genital tract sepsis, chorioamnionitis, endometritis, especially group A streptococcus, are common organisms causing sepsis, and a significant number of mothers still die from sepsis in these parts of the world. 3 common organisms, group A streptococcus, E. coli, and Klebsiella pneumonia are common pathogens that is associated with significant mortality. What are the other challenges apart from these 6 medical conditions I illustrated earlier? The postnatal period, the fifth trimester, is also a time where women lack sleep. Women complain of fatigue. Women have pain. They've got mental health issues, blues, and sometimes depression and low mood. They've got breastfeeding issues. Yes, ladies and gentlemen. Some women may feel less of a mother if they're not being able to cope with breastfeeding. And almost everyone, especially in the first pregnancy, needs some kind of support with regards to breastfeeding. And apart from pain, fatigue, lack of sleep, some may also suffer from incontinence. And these are all the challenges added to the mother who's already at risk of medical conditions in pregnancy. What are the additional challenges in Malaysia? The incidence of defaulters in the postnatal period is as high as 40%, just like how 40% of pregnancies are unplanned in Malaysia. We live in an Asian society where we have got a lot of cultural rituals, unevidence-based rituals, where women do not drink, women are confined, women are not given healthy food, and women are denied fluids, hydration, and are given a lot of supplements and additional rituals, which I think will increase the risk of a mother who's already at risk. And these postpartum rituals are more common among certain ethnicities. We also live in an era where we have a postpartum migration pandemic, where women after delivering in a state will often always go back to a kampung, to a hometown, to spend for postnatal care, and there's a significant shift of care from being high risk in a tertiary hospital to a postpartum migration, which could be in a hometown which is remote or far from quality tertiary major hospitals. Hence, this may cause fragmented care. A pregnant mother who would have seen a consultant, a subspecialist, a specialist, an expert about 10 times would now no longer see an expert in the postnatal time. And this fragmented care will, of course, indirectly increase the risk and eventually mortality. There seems to be a fragmented care between tertiary and primary care. A care which is so beautifully integrated in the antenatal period is often de-escalated quickly to primary care for all mothers, including high-risk mothers in the postnatal care. And that is where I think we should now shift our focus and how we can strengthen the 5th trimester or the postnatal care. So ladies and gentlemen, what are the 6 domains that I think we should focus? We should focus on breastfeeding and infant care. Mothers should be taught about identifying babies for jaundice, babies who are septic, babies who are having failure to thrive, or babies who are having feeding issues. We should also talk about future pregnancies, about contraception. Confinement is not contraception, ladies and gentlemen. We should talk about how they should empower, they should plan, they should have the rights and the dignity to decide when to get pregnant. And we should also talk about sexuality and when they can resume their sexual activities. Also a time to address adverse pregnancy outcomes, because many of these outcomes can be modified, can be prevented. And patients with adverse pregnancy outcomes should not have routine postnatal care on day 42, but they should have a tertiary postnatal care within the specialist hospital to discuss, to talk, to empower of how they can do better in future pregnancies. The postpartum care is also an important time to ensure the mother who's gone through labor, which is equivalent to a marathon, has made a complete physical, emotional, and mental recovery. And ensuring complete physical recovery should be within the first 3 weeks, not day 42, but within the first 3 weeks to ensure the mother has recovered. This is important to screen for mental health and for mothers with chronic diseases, with cardiac diseases, with hypertension, with malignancies, should have an integrated care. The care which is high in quality in the antenatal period now should not be de-escalated, but should be continued in the primary care, taken over by the physicians and primary care specialists. It should ensure that women remain healthy, not only during pregnancy, but also after pregnancy and in between pregnancies. So here is my suggested algorithm for the 5th trimester. Please do not just give her a TCA 6 weeks. 42 days is far too long. 1 in 2 mothers die in the postnatal period. Focus on 3 things: physical health, social health, psychological health. These are 3 components for a holistic approach. Every mother needs to be empowered about rituals which are not beneficial. She should not and never be confined. It's important to individualize care. All patients with chronic disease should have a documented care plan on who to see, what to do, and how to ensure she remains healthy. We should not just talk about obstetric care, we should also focus on future cardiometabolic risk. So all patients who have GDM should be screened yearly for diabetes. All patients with preterm deliveries and all patients with preeclampsia ideally need to be followed up by a physician or a family medicine specialist, because these patients have got a higher risk of cardiometabolic risk. Ladies and gentlemen, we should look beyond pregnancy. We should be holistic in our care. And all patients with an adverse pregnancy outcome, with a miscarriage, with a stillbirth, with a neonatal death, should be seen sooner, should have additional support, should have access to a specialist, not when she's pregnant in the next pregnancy, but in the current pregnancy, in the postnatal period, to discuss, to talk on ways she can reduce her risk. The current postpartum management, our patients now have got home visit on day 1 and day 3, home visit on day 5, day 7, day 11, and they only get to see a doctor on day 42. Now, this is a bit too many of home visits, but what I believe is not the number of visits, but is the quality in each visit. And this is what we should now change. The review by an expert, the review by a doctor, the review by a primary care doctor should not be standardized for day 52, but it should be individualized, and mothers should be seen before day 42. So just like our antenatal color coding of white, green, yellow, and red, I believe perhaps we should now embark on a postnatal color coding as well. And perhaps you can use two codes, yellow and red. The mother's coded red, then she should see a specialist in a tertiary hospital. The mother's coded yellow, then she should see a medical officer in the primary healthcare. It is important to risk stratify patients also after delivery so that they get appropriate care. And hence, I believe there should be two color codings. One, the antenatal color coding, and two, the postnatal color coding, because 1 in 2 mothers now die in the postnatal period. So with that, ladies and gentlemen, what is my recommended algorithm? Do not just discharge with EOD blood pressure check. There's no benefit of checking blood pressure alternate days. Blood pressure should be daily, not alternate days. So all mothers with preeclampsia with hypertensive disease, check their blood pressure daily between days 3 to 10. All mothers have a VTE risk assessment on day 10. It is also important to ensure that the baby has recovered, feeding well, not jaundice, not having feeding issues, the mother is coping well. It's important to incorporate infant check with VTE check on day 10. All high-risk mothers and all mothers should be reviewed by a healthcare professional, ideally a doctor, either a medical officer, a family medicine specialist, or even an obstetrician, or even a subspecialist within 1 to 3 weeks to screen for VTE, to ensure she's made a complete physical recovery, to highlight the 6 domains, the 5 diseases, and the 6 conditions I mentioned earlier. So the first contact should be within the first 21 days, not 42 days. And then between days of 3 to 12 weeks, it should be an ongoing follow-up. It should not be 2 checkpoints, but it should be a continuous follow-up, seeing her on day 10, seeing her on day 21, and seeing her in between if she needs additional care, and eventually transfer her care with the same quality to a primary care physician or to a general physician. And this is called an inter-pregnancy care, where the care for a woman in the reproductive health group is not only optimal before pregnancy, during pregnancy, after pregnancy, but also in between pregnancies. And that brings to the concept of inter-pregnancy care. So ladies and gentlemen, to summarize 5 trimesters, 1 in 2 maternal deaths in Malaysia occur in the 5th trimester. I think we need a paradigm shift in the postnatal care. We now need to shift our focus to be as intense in the postnatal period in the 5th trimester. It's important to review all pregnant mothers between days 10 to 21, first 10 days for blood pressure, the next 21 days for VTE and mental health soon after. It's important to risk stratify these mothers and embark on a postnatal color coding system, because this seems to be a risky phase in a mother's life. Think of 6 diseases and 6 domains which I mentioned earlier. It's important to have a checklist. It's important to educate our healthcare givers, our midwives, on the importance of these domains and on the importance of the 5th trimester. Think of VTE, think of sepsis, and think of preeclampsia. So ladies and gentlemen, to summarize my talk, the way forward, I believe it is time we evolve from 3 trimesters to 5 phases, which I call it the 5 trimesters. Because I believe the first 12 weeks before pregnancy and the next 12 weeks after delivery is just as essential, if not more, as compared to a pregnant mother. If we are to reduce maternal deaths and complications from medical diseases, pre-pregnancy care is crucial. If we are to reduce maternal deaths in Malaysia, which has been static for the last 22 years, we should now focus on postnatal care, because 1 in 2 mothers in Malaysia die between day 10 to day 42. We need to have a paradigm shift in obstetrics. It is not just the number of visits, but it is the quality of visit. It is not just a focus on antenatal care, but we should ensure that these vulnerable mothers have got access to see a specialist, to be reviewed by an expert before, during, after, and in between pregnancies. And ladies and gentlemen, to stand before a mother alone is not enough. It's time to stand with the mother, because nothing is more precious than the journey towards motherhood. With that, I thank you so much for your attention. If you have any questions, I'll be more than happy to answer them. Please connect to us via www.obstetricmedicine.my. And ladies and gentlemen, we are just a few weeks away from the MOMS Malaysian Obstetric Medicine Scientific Conference. We have limited physical places left. If you'd like to know all about maternal medicine, please come and join us on site. I look forward to see all of y'all in the next few weeks physically at the World Trade Center. With that, thank you so much for your kind attention.